You are listening to a revision deep dive, and we are diving straight in. If you are a resident prepping for the FRCS Plastic Surgery Board exams, you are in the exact right place.
Absolutely.
Before we start, press follow on the show right now so you get more of these high-yield revision deep dives directly in your feed. And, if you learned something valuable today, please rate the show.
Yeah, and to take your prep to that next level, get a premium subscription. That's how you listen to our Journal Club and Clinical Cases deep dives.
Right. So today, we are completely tearing down perineal anatomy and the principles of surgical reconstruction.
We have a very strict agenda for today's session. I mean, to crush this section of your exams and actually perform on the table, we're going to master perineal anatomy and its rigid boundaries.
Yeah.
We're going to thoroughly understand defect assessment, and we're going to lock down the specific flap options for surgical reconstruction. Let's get to work.
Okay, so let's unpack this. What are the exact boundaries of the perineum? We need the precise anatomical landmarks here.
Right. Think of the perineum as a 3D diamond. It's situated at the base of the pelvis, entirely inferior to the pelvic diaphragm.
So anteriorly, you've got the pubic symphysis and the inferior pubic rami.
Exactly. And then laterally, you are looking at these ischial rami and the ischial tuberosities.
Here.
Posteriorly, your boundaries are the sacrotuberous ligaments and the cosciacates.
And the reason we care so deeply about those rigid, bony
The
boundaries...
symphysis, the tuberosities, the cosciacates.
Right, because they dictate the absolute limits of our local flat mobility. I mean, the perineum isn't just some flat surface. It's a highly dynamic, weight-bearing region.
It is. When you are designing a reconstructive strategy, those bony landmarks are your non-negotiable borders.
So how do we divide this anatomical space when we're actually evaluating a patient?
You need to visualize an imaginary transverse line. Just draw it, joining the anterior ends of those two ischial tuberosities. That single line bisects our diamond. It divides the perineum into two distinct areas. Anteriorly, you have the urogenital triangle that contains the female external genitalia, or in males, the root of the scrotum and penis.
And then posteriorly, you have the anal triangle, which obviously contains the anus.
Right. And sitting exactly at the midpoint of that transverse line, separating the two triangles, is the perineal body. Do not gloss over this structure in your revision.
No, it's a critical tendinous center. It acts as the central anchor point where several crucial muscles converge and attach.
Right, like the levator ani and the external anal sphincters.
Exactly. If the perineal body is compromised, say during an oncological resection or severe trauma, the structural integrity of the entire pelvic floor is threatened.
Let's focus on that deep structure then. We need to break down the muscular layers holding everything together, starting with the pelvic diaphragm. Think of the pelvic diaphragm fundamentally as a hammock. It's stretched between the pubis, the coccyx, and the lateral pelvic walls. Its primary job is keeping the pelvic contents inside the pelvis against the constant force of gravity.
And it is formed by two main muscle groups, right? The two levator ani muscles and the two coccygeus muscles.
Correct. And the levator ani itself is composed of the puborectalis, the pubercoccygeus, the iliococcygeus, and the levator prostati, or levator vaginae in females.
That breakdown is vital, but we should highlight the ultimate exam trap here.
The puborectalis.
Yes, the puborectalis. These muscles unite posterior to the anorectal junction. They form a crucial muscular sling, which actually pulls the junction forward.
Right, creating the physical angle between the rectum and the anal canal. That anorectal angle is exactly what maintains fecal continence. When you are assessing a patient for reconstruction, understanding if that sling is intact dictates your entire functional goal.
Now let's detail the urogenital triangle, moving from deep to superficial.
Okay, so deep down you have the urogenital diaphragm. This is a muscular sheet attached to the sides of the urogenital triangle. It's pierced by the urethra, and in the female, the vagina.
And the anterior and posterior parts of this diaphragm are formed by the deep transverse perineal muscles, while the middle part is formed by the sphincter urethrae muscle.
Precisely. Overlying that urogenital diaphragm, meaning superficial to it, is a tough layer of fascia termed the perineal membrane.
And then superficial to that perineal membrane, you find the superficial perineal pouch. For the boards, you absolutely must know the three key muscles contained within this pouch.
The bulbospongiosus muscle, the ischiocavernosus muscle, and the superficial transverse perineal muscle.
But keep in mind the clinical context here. In the female, these muscles are less well developed, and the bulbospongiosus is physically pierced by the vagina.
Which drastically changes the spatial relationship compared to male anatomy. You have to visualize that difference.
Let's move posterior to that imaginary transverse line we talked about, the anal triangle.
Right, so the anal triangle comprises the anus, the external anal sphincter, the levator ani, and importantly, the ischial fossa.
Those fossa are incredibly high yield because they contain the internal pudendal vessels and the pudendal nerve. And that nerve supplies the vast majority of perineal sensation.
And you must know exactly where that neurovascular bundle travels. It runs in Alcock's canal.
Alcock's canal, yeah. That's a fascial tunnel overlying the obturator internus muscle on the lateral wall of the ischial fossa.
Exactly. During dissection or flap elevation in this region, if you stray too lateral and deep into that obturator internus fascia, you will severely compromise your patient's sensation and regional blood flow.
Speaking of blood flow, we can't talk reconstruction without blood supply. The perineum has an incredibly rich arterial network from two main sources. First, the femoral artery, which gives off the superficial and deep external pudendal arteries.
And second, the internal iliac artery, which gives off the internal pudendal and inferior gluteal arteries. These branches anastomose freely across the whole region.
Which is the exact physiological reason we have such a versatile flap arsenal. This rich anastomotic network is what allows us to design multiple pedicled flaps with a highly robust blood supply.
It's also worth noting that perineal skin is extraordinarily mobile. I mean, it has to accommodate the full, extreme range of hip joint movement, as well as the mechanical stresses of defecation, sexual intercourse, and childbirth.
So, what does this all actually mean for the defects we see on the table? Let's be honest, perineal reconstruction is one of the most hostile environments we operate in.
It really is. You will most commonly see defects resulting from the radical resection of gynecological, colorectal, and urological malignancies,
You'll also see massive tissue loss from the aggressive debridement of severe sepsis.
like Fournier's gangrene.
Exactly.
Um,
As well as inflammatory bowel diseases like Crohn's disease and ulcerative colitis, and of course, devastating pelvic trauma.
It is a uniquely hostile surgical bed. You're constantly fighting gravity, immense external pressure from sitting, and very often tissues that have been completely nuked by radiation.
Let's focus heavily on the oncology aspect. You must be familiar with VIN, vein, and AIN.
Right. Vulval, vaginal, and anal intraepithelial neoplasias. These are premalignant lesions highly associated with human papillomavirus.
Specifically the high-risk HPV 16 and 18 strains.
Yes, as well as smoking and immunosuppression. The dysplastic changes are graded from 1 to 3, similar to cervical intraepithelial neoplasia. High-grade dysplasia frequently progresses to invasive squamous cell carcinoma, or SCC.
The pathology data is what drives our surgical aggression here. The gold standard treatment for VIN is local excision. Why? Because 12 to 17% of VIN excision specimens already contain invasive SCC at the very time of surgery.
Even more critically, 40 to 60% of untreated WIN lesions will eventually progress to invasive SCC.
While there are alternatives like topical imiquimod and laser ablation, their response rates are lower and require exhaustive, close follow-up.
The protocols for vein and AIN follow a similar escalating pattern, from observation for low-grade all the way to ablation or excision for grade 3 or multifocal disease.
When these lesions do progress to invasive malignancy, the massive oncological resections begin, and that is when plastic surgery input becomes absolutely critical. Take an abdominoperineal resection, an APR for a low rectal tumor, for example.
What's fascinating here is the stark contrast in the healing data. If the general or colorectal surgeons attempt direct primary closure of these massive perineal wounds, the delayed healing rate is an astronomical 40 to 70%.
The wounds just simply break down.
They do. But when plastic surgery is involved and robust flap reconstruction is utilized to actually fill the dead space, that complication rate plummets to 15 to 25%.
That is a massive paradigm shift in patient morbidity.
It is. That is exactly why the anal cancer position statement explicitly dictates that plastic surgical input should form part of the multidisciplinary team from day one.
Let's map out the standard approaches for these invasive malignancies. For vulval SCC, it's usually treated by wide excision with 1 centimeter margins, capturing any adjacent VIN.
Larger resections may demand a defunctioning colostomy to protect the surgical site from fecal contamination. An elective inguinal lymph node dissection is often required.
Vaginal SCC is typically treated primarily with chemoradiotherapy, but if you have high posterior tumors, advanced stage, or recurrence, surgery is mandated.
And this often involves total pelvic exenteration due to the high risk of fistulation into the bowel or bladder. which leaves behind an enormous void.
Anal SCC follows a similar primary chemoradiotherapy route with surgery reserved for salvage, again, usually involving an APR.
And for low rectal tumors, predominantly adenocarcinomas, an APR is standard, resulting in a permanent end colostomy. Depending on the local invasion, the resection might take the posterior vaginal wall, bladder, prostate, seminal vesicles, and even the coccyx or sacrum. You're left with a cavernous, non-collapsible pelvic cavity.
Right, so before we cut, we assess. How do we systematically assess these defects before reconstructing? We rely on 4 core pillars. Pillar 1 is volume deficit.
Superficial lesions might just take a skin graft or a thin local flap, but if you have significant dead space and you don't fill it, the intestines will physically descend into the empty pelvis under the force of gravity.
Exactly. That is a perineal hernia. It is a catastrophic mechanical failure of the pelvic floor. A bulky, volume-filling flap is absolutely required to block that descent and substitute for the excised pelvic diaphragm.
Pillar 2 is radiotherapy. You have to know if the surgical field has been irradiated.
Irradiated fields are an absolute contraindication for the use of local tissues. Radiation causes progressive endarteritis obliterans. It completely chokes off the microcirculation.
If you try to advance a local irradiated perineal flap into a massive defect, it will necrose. It massively increases the incidence of complete wound breakdown and fistulation. You must look outside the radiation zone for your reconstructive tissue.
Pillar 3 is diversion. When fecal and urinary diversion is planned, the specific location of the stomas on the abdominal wall must be coordinated with the MDT.
This is especially crucial if you plan to use a rectus abdominis flap. A poorly placed stoma can compromise your superior epigastric vessels or physically block your flap harvest.
And the final pillar, pillar 4, is function. We're not just filling a hole here. You must rigorously evaluate whether sexual function, as well as fecal and urinary continence, can be realistically restored.
Or if you are simply managing tissue coverage.
All right, so we've mapped the defect, we know the volume deficit, and we know if radiation has nuked the local tissue. Let's look at our toolbox. Our main reconstructive goals are the importation of vascularized, non-irradiated tissue to manage dead space, provide a substitute for the pelvic floor, or reconstruct the vagina. But we systematically avoid free flaps in the perineum.
We avoid free tissue transfer entirely here because of the unique biomechanical hostility of the perineum. The external pressure exerted on a microvascular anastomosis during lying, sitting, and walking makes it vastly riskier than in a head and neck or extremity reconstruction.
The shear forces will just thrombose your pedicle.
Exactly. Therefore, we rely almost exclusively on robust pedicled flaps.
Let's run through the high-yield fasciocutaneous options, starting with the lotus petal flap. This flap is named because the possible skin paddles fan out from the perineal midline like the petals of a lotus flower.
In practice, you design the paddle lying in the buttock crease. It is based on unnamed perforators near the midline of the perineum, usually stemming from the internal pudendal artery traversing the ischial fossa.
The anastomotic density here is so rich that finding a specific named vessel is inconsequential.
It's an incredibly reliable workhorse for superficial coverage. You can transpose it or advance it as a VY flap. It is particularly excellent for resurfacing the defects left behind after a radical vulvectomy, providing sensate, durable skin.
Next, we have the superior gluteal artery perforator, or SGAP flap. The superior gluteal artery is a major branch of the internal iliac artery. It emerges from the pelvis superior to the piriformis muscle, running deep to the gluteus maximus.
For the boards, you must know the surface marking. It is exactly 1/3 of the way along a line drawn from the posterior superior iliac spine, the PSIS, to the apex of the greater trochanter.
The SGAP is fantastic for tissue match, but be acutely aware that perforator location variations are very common.
Sometimes the perforators are situated too far superiorly or laterally, making it physically difficult to rotate the flap far enough to reach low anterior perineal defects without placing the pedicle under severe tension.
Which brings us to the inferior gluteal artery perforator, or IGP flap. The inferior gluteal artery is also an internal iliac branch, but it emerges from the pelvis inferior to the piriformis.
The surface marking here is exactly 1/2 of the way along a line joining the PSIS and the ischial tuberosity. It travels infralaterally, giving off numerous myocutaneous perforators to the inferior buttock skin.
And importantly, the inferior gluteal artery gives off a descending branch.
Right. If we connect this to the bigger picture, that descending branch forms the basis of the posterior thigh flap.
For the posterior thigh flap, you can raise it as a large transposition flap, Or you can elevate almost the entirety of the posterior thigh as a massive VY advancement flap. It survives based on both that descending branch of the IgA and the profunda femoris perforators.
And those profunda perforators are located along a line joining the ischial tuberosity to the lateral femoral condyle.
A massive advantage of the posterior thigh flap is that it is natively sensate. It incorporates the posterior cutaneous nerve of the thigh.
Which is incredibly valuable for patients needing sensory feedback in the reconstructed perineum to prevent pressure sores when sitting.
Let's discuss the pudendal thigh flap, commonly known as the Singapore or Wee flap. This is a fasciocutaneous flap based on the posterior labial branch of the internal pudendal artery, with sensory supply from the corresponding posterior labial branch of the pudendal nerve.
You design it on non-hair-bearing skin right in the groin crease, lateral to the labia majora, keeping its base posterior at the level of the posterior fourchette.
This is the classic option for vaginal reconstruction. To visualize this, imagine taking two flat strips of tissue from the groin creases. You raise bilateral flaps, tunnel them medially, and suture their long edges together completely outside the body to form a sleeve.
Then, you push that entire sleeve inside out into the pelvic cavity. By inverting it, the skin of the thigh now forms the inner epithelial lining of the neovagina.
I want to touch on the anterolateral thigh, or ALT flap. We use it everywhere else in the body, and it's based on the descending branch of the lateral circumflex femoral artery.
To use it here, it has to be tunneled medially, passing deep to the sartorius and rectus femoris muscles to reach the perineum. If you need bulk, you just include the vastus lateralis muscle.
The ALT is great, but here is the critical danger zone during that specific tunneling maneuver. You must meticulously identify and preserve the motor branches of the femoral nerve innervating the rectus femoris.
If you blindly tunnel and crush or sever those nerve branches, your patient will wake up with a severely compromised ability to extend their knee.
Here's where it gets really interesting. What about the massive cavernous defects? I'm talking about a post-radiotherapy abdominoperineal resection or a total pelvic exenteration.
When you face a heavily irradiated pelvic cavity, local gluteal or perineal flaps are entirely off the table. They will die. You need to import massive, well-vascularized bulk from completely outside the radiation zone to pack that dead space.
So we turn to the myocutaneous options, and the undisputed heavyweight champion here is the vertical rectus abdominis myocutaneous, or VRAM flap. The VRAM is essentially your heavy-duty moving blanket.
It is based on the deep inferior epigastric artery. You can augment the flap's volume and reach by extending the skin paddle obliquely all the way up to the costal margin.
The inset is where the magic happens. You harvest the rectus abdominis muscle with its overlying skin paddle, rotate the entire complex 180 degrees on its long axis, and fold it posteriorly directly over the pelvic brim.
It drops deep into the pelvis, bringing a massive, healthy, non-irradiated blood supply to heal the hostile perineal wound. And crucially, employing a fascial-sparing harvest technique on the abdominal wall prevents ventral hernias and allows for primary closure of the donor site.
What about the inferior gluteal artery myocutaneous, the IgAM flap?
The IgAM is anatomically identical to the IG gap we discussed, but instead of painstakingly dissecting out just the perforators, it purposefully includes a strip of the underlying gluteus maximus muscle.
Specifically, you take less than 20% of the muscle's width.
Right. You sacrifice a small fraction of muscle function specifically to provide additional, highly robust bulk for dead space management in cases where a purely fasciocutaneous flap would leave a void.
Let's round out the flaps with the gracilis. Based on the medial circumflex femoral artery, you can raise it with or without a skin paddle. Though keep in mind that the distal skin paddle over the lower third of the muscle is notoriously unreliable and prone to necrosis.
The gracilis muscle itself is unparalleled as an interposition flap. When colorectal or urology calls you for a complex, recurrent rectovaginal or vesicovaginal fistula, packing a well-vascularized gracilis muscle between the repaired structures is the absolute best way to prevent recurrence.
For vaginal reconstruction, you can use bilateral gracilis myocutaneous flaps, suturing the skin paddles together to fabricate a tube.
However, the anatomy creates a severe limitation here. The proximal supraomedial location of the vascular pedicle severely restricts how far you can rotate the flap upward, which inherently limits the depth of the reconstructed neovaginal vault.
Finally, what about non-flap alternative options for these reconstructions? We primarily look at two things, the omentum and the colon. The omentum can be mobilized off the transverse colon and simply pulled inferiorly into the pelvis to fill dead space.
It brings fantastic blood supply to irradiated fields, but mechanically it is just too soft. It is not robust enough to act as a structural hammock to prevent the pelvic descent of the intestines.
Therefore, your patient is still at a high risk for a perineal hernia. Plus, if they've had previous abdominal surgeries, the omentum might be scarred down and completely unavailable.
And the colon segment. You can isolate a 12 to 14 centimeter segment of the rectosigmoid colon based strictly on the superior hemorrhoidal artery.
You transpose it down to the perineum and suture the bowel lumen closed at the proximal end to form a blind-ending tube.
This effectively reconstructs a very natural-feeling vagina with excellent depth. However, because it is colonic mucosa, it is notoriously prone to severe chronic oversecretion of mucus.
Which creates a massive quality of life issue for the patient, requiring constant management.
Exactly.
Let's do a rapid recap of what we covered today. We dissected the precise 3D boundaries of the perineum and the critical muscular hammock of the pelvic diaphragm. We established exactly why plastic surgery flap coverage drops, delayed healing rates from up to 70% down to 15% in these massive oncological resections.
And we've mapped out the entire arsenal of pedicled flaps, from the lotus petal and Singapore flaps for superficial and vaginal defects, all the way to the heavy-duty VRAM for massive irradiated dead space.
Mastering this anatomy and these reconstructive principles is absolutely non-negotiable for the FRCS.
This raises an important question for you to consider as you study. When you are on the table dealing with total vaginal reconstruction, you are constantly navigating severe functional compromises. How would you systematically weigh the decision between importing a rectosigmoid colon segment that successfully creates excellent depth but constantly oversecretes mucus versus utilizing bilateral gracilis flaps where the tissue is more manageable but the pedicle anatomy fundamentally limits the depth of the vault?
Reconstructing the perineum is never perfect. It is fundamentally about choosing the lesser functional compromise tailored to your specific patient's life.
Right.
That is exactly the kind of high-level surgical reasoning you need to demonstrate for the board exams. Leave a comment or question about today's deep dive, and we will see you in the next revision session. Keep grinding.